Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. An educator and researcher from Upstate is exploring contemplative medicine. Here to explain what that is and how it's being incorporated into training at Upstate is Dr. Hesham Masoud. He's a vascular and interventional neurologist and also the director of Upstate's Simulation Center. Welcome back to The Informed Patient, Dr. Masoud.
Thanks, Amber. Pleasure to be here.
So what is contemplative medicine?
It's an umbrella term that essentially describes an amalgam of, what, would be considered these mind-body practices. So that's this idea of mental training through meditation/mindfulness of action, compassion training exercises, breathing exercises, movement, mindful movement, things like yoga. All of these things would be under the umbrella of something that you might refer to as contemplative practices. And so contemplative medicine enfolds those practices in the context of, the navigating and delivering of care. And that includes the personal side of things.
Is it closer to Eastern medicine than Western medicine, or can you have contemplative medicine in Western medicine?
Yeah, I think so. Generally speaking, a Western approach to disease is one that emphasizes detection and intervention. And, a contemplative one would emphasize a stage which would include awareness, cultivating essentially detachment, but within compassionate presence, which is to say, inserting introspection into the active endeavor. So that means things like patient-provider relational presence, modulation of stress, open awareness of the environment versus focused awareness. So you can see it is essentially more about seeing things as they are before action, as opposed to quickly sorting and acting. So you can imagine that kind of cultivation of skill would have its value in certain instances across a range of things that happen in healthcare.
Well, is this a philosophical approach to medicine that is new, or is it a philosophical approach that's very old?
Well, so very old. We're essentially doing this discussion that is describing this, introspective, meditative, and reflective practice that has been part of personal development and what's been referred to as transpersonal psychology all the way back to, Greek philosophy. And a lot of these frameworks come from Buddhist and Hindu philosophy, even Christian prayer of being mindful is, another description of mindfulness. In a way. So a lot of these things are really just weaving together things that have existed for quite a long period of time, as we've just sort of wrestled with what it is to be human.
Can you tell us about your experience at the Zen Center in Manhattan where you completed a contemplative medicine fellowship?
Yeah, so it really kind of was born out of some of what you've seen this field sort of develop around the value proposition towards professional development. So that was sort of my level of engagement with it, and interest was precipitated by wanting to get more balance, more understanding of the drivers of burnout professionally. And to kind of have a better understanding of how to operationalize what people are talking about when you read about wellness and these things that people write about in the context of healthcare burnout, which is a big problem and has a certain cost to it that was highlighted by the Surgeon General not long ago. So that was my driver, was that, this is a program that essentially was using the synthesis of Buddhist contemplative tradition in contemplative medicine fellowship that was, the first accredited one in the United States. And they had published data from their first cohorts that showed that it was really delivering on personal accomplishment and a lot of the drivers that are protective against burnout. And so That's what sparked my interest in looking into it. It was this very achievable one in the sense that it did not require me to be cloistered away in a temple for a year, but it was a regular engagement with the curriculum that was formalized and holistic and tied to very specific healthcare contexts. And that would mean there would be remote Zoom meetings, there would be half-day sessions, there are lecturers who come and there are discussions, reading materials, and then there are these retreats that you go to in person that were 4-day intense retreats where there's a lot of discussion. There are these dyads and triads of the fellows discussing things together within obviously the context of the curriculum. And, you can imagine lots of meditative practice. And then it's culminating in a capstone project, which is really what drew me is how formal everything was. And at the end, you would have something tangible from the experience beyond the accredited, validated training that CMEs or whatever. It was that you would have this capstone project. And so this capstone was essentially the idea that you would, the application that I had was that I would bring a simulation methodology to how to instruct contemplative medicine. And so that's what I designed, and then we ran it through a cohort here.
I want to hear more about the capstone project, but your fellows, were they other physicians or other people in healthcare? And did they
Yes.
come from all over the country or?
Yes. And it was, one of the most interesting parts of the fellowship was how you saw certain parts of it be more valuable than what you anticipated. And one of the most valuable things was how heterogeneous we were as a group of healthcare providers, in the sense that there were the gamut, nurses, doctors, nurse practitioners, physical therapists, educators, but all fairly similar in terms of their introspective approach to trying to achieve some balance and or further understanding into how these things can affect practice. So it was a very cool network to be plugged into, and it is enduring. It's been almost a year now, and there's been, we still connect, and that is part of the curriculum, you realize, in that the building of community is inherently protective. And so that is something that is instructional also. And you can see that organizations like Upstate also do that, a lot of community building. And community building within a professional expression can be protective against some of the difficulties that one has to be resilient against. So lots here that was familiar.
You're listening to Upstate's The Informed Patient podcast with your host, Amber Smith. My guest is Dr. Hesham Masoud, the director of the Simulation Center at Upstate. And I want to know more about your capstone project, but I feel like I ought to ask you to explain what the Sim Center is to our listeners.
The Simulation Center is essentially an immersive environment that can recreate the places where healthcare is delivered. And it's a recorded environment such that the learning that occurs there can be, scrutinized to the endeavor of teaching whatever it is that we're trying to teach. And so that might be better decision making about the delivery of a drug in an emergency setting. It might be learning how to do a complex task more proficiently. It might be learning how to communicate with others, like patients and families, to a given purpose. And that's where my project kind of came in, was leveraging this immersive environment of how the simulation lab has a part of it that looks like a hospital, where you can round between patient rooms. And we had a long enough hallway, and the hallway looks like a real hospital ward hallway. And we have a speaker that piped in the ambient sounds of a hospital. And then we had 2 patient scenarios on either end of the hall, such that you had teams that would round on each patient. And the patients had scenarios that were very reflective of things that you see in the regular stroke service, related to instances of medical futility. And, it's interesting because we had a conversation not too long ago about how there are new stroke therapeutics looking into how do we improve upon benefit to a patient beyond opening of the vessel because even when we open up the vessel fully, or the artery to say, that was blocked, this patient's not 100% of them improve. 30% of them still don't benefit. And so there's this other place where we're not moving the needle, even though we've done, quote unquote, everything correctly. And so you have to engage with patients who sometimes are part of that 30% group. And, you might have to talk to them about decision making related to prevention of stroke. And then you can imagine how organically that can be contextualized into some feeling of futility. And then you can imagine Western medicine really lends itself towards one of problem solving. And here there's a problem that can't be solved. And so how do you manage your own internal frustration? So that was one case. And then the other case was one where there is a gap in knowledge transfer to the patient such that they can make an informed decision. But there is a disconnect with the team's perception that the patient has actively refused something they would benefit from. And that was an example of, if you have open awareness and you bring beginner's mind, so to speak, to that endeavor, you won't just go with what the chart said about the patient. You will revisit that in light of the context of what's really going on here. And in that early instance, that patient would, in how we have it unfold, which is not infrequent, if you ask a couple of questions, you'll notice the patient didn't have a good understanding, but they're very able to understand. It was a clunky communication that honestly is hard to even pin down. And so that was the second one. And we had designed things in the environment such that we would have the participants have to navigate between this idea of focused awareness, which is to say, I'm focused on one thing, and open monitoring, which is I'm aware of the context of the greater environment that I'm in. And so focused on the bedside encounter, but aware of the ambient noise that may, and the things that are going around me that may get in the way of the endeavor. And so we had designed some beeping that you can shut off. And it was interesting to see who shut it off reflexively, when they shut it off in the encounter, things like that. And so the way that we designed it was, there was first a didactic where I presented about the concept of contemplative medicine and some of the reasons why I think it is uniquely well positioned to teach affective learning objectives. And then we go through a couple of them, not practiced, but talking about them conceptually and branding them. So the pause, which is essentially, evaluating before acting, slowing things down to fully understand. Beginner's mind, which is essentially having a fresh expression every time you're engaging with something to avoid loading it with bias. And then not knowing, which is this idea that, there are instances where we don't have knowledge, and we need to be able to navigate that and sort of validate that within ourselves as well. And no separation. No separation is this idea that when we are engaging with each other, we are actually connected on a way. And so if we can have this awareness that we're connected, at least in our ability to interpret each other's emotions as human beings in the same space, and we're not separated, then it's easier for me to navigate emotional challenges that might occur, because we're all, sort of navigating things that may trigger our emotional centers, our amygdala, and that can obfuscate our ability of our executive function to override that. So these were these branded techniques, and then they would go and have the opportunity to do them at these two encounters. And then afterwards, we would do a debrief. And I bookended it with a pre and post survey that included some attitudes related to practice, which is really interesting to see people's attitudes related to things like contemplation and introspection. And then we also have a longitudinal feedback loop where in a couple of months, we're going to have them redo these evaluations to see if this stuff was integrated into their practice. And there's a reflection post as well, where they'll watch the video and then give us a sort of unstructured, free-form thought, less than 250 words about the experience. And so these things were all meant to reflect this idea of, what is contemplative medicine? How do I operationalize it? How do I apply it? And then sort of a nod towards narrative medicine, which is this idea that, writing and hearing patient stories affords another avenue of communication and insight into disease. And, using writing and journaling can also be a way of contemplative practice for one's own process. So I wanted to weave that in there with the reflection post. And so that was our design, and we ran that through with the neurology residents as part of an initiative from the wellness residents. So every year they have a wellness resident. So we worked together to have this go with the neurology residents, and we collected some data about it and plan to iterate on that.
Now, I understand this is a new way of folding this sort of learning into professional medical education. What made you want to try this? Did this idea just come up when you were in the fellowship?
So, I think there were two things that spoke to me. And by that, I mean, I think were very intuitive. And I was like, oh, this is an intuition I should share. And one was that this traditional Eastern philosophy really has legs in helping us get a framework to interpret some difficult things that we see at the bedside. And, as a stroke neurologist, you can imagine, seeing people survive through disability can be really inspiring. You're privy to some really humbling human experiences of resilience. And in that, it's hard not to internalize it, like any difficult job in healthcare. And so, there are these four truths, the four noble truths. In Buddhism, there are a lot of lists, which I kind of like. These ideas are things that are quantified, delineated, defined, and listed, and then integrated. So things are very, quote unquote, tangible in terms of them being philosophical frameworks that can be applied for mental training. So just by virtue of the design of it, it lent itself to me thinking that, oh, this would be useful. And there are these four noble truths that really mirror the process of what a doctor does. And this is stuff that Norman Fisher wrote about. The Four Noble Truths are, there's suffering, there's an origin of suffering that can be traced to personal craving or individual craving. There's a way to stop suffering, and there's a path to the cessation of suffering. So the way to stop suffering is a certain way, and the path is this other eight noble-fold path. But basically, those four truths are, oh, this is suffering, this is the diagnosis. The origin of suffering is our attribution of causality to a diagnosis. What caused this? What is this? What caused it? And then the cessation of suffering is essentially the treatment. What's the treatment? And then the path is the prescription. So really, it's like, let's page Dr. Buddha, like this is very clear one-to-one. So to me, that was like, oh, this is a useful framework. And the inherent piece of it is the acknowledgement that, yeah, it's rough. We're dealing in healthcare. It's suffering inherent to it. They're not coming to us, not in a disease state. Certainly not, the context of my job as a stroke doctor and interventionalist. So that lent itself to that interpretation. The other thing that I thought was really interesting was the stories really are evocative and have relevance to clinician burnout. And clinician burnout is very much driven by, like we were talking about, this Western leaning towards sorting and treating, certainty, right? And in that, you can imagine this can build a myth of being invulnerable as a clinician, one who is knowing and decisive and therefore invulnerable to indecision, which is often informed by the understanding of how things are gray and not black and white. And so that drives burnout. The professional identity drives burnout. And so there's this really interesting story that, it's not that interesting in the sense of like, it's a brief story, but I thought it was very evocative of the burnt out doctor, which is this story of Avalokiteshvara, who was this bodhisattva character, which is this idea of a sentient being, this being that has achieved enlightenment, but has decided to stay on earth to help others try to achieve enlightenment. This idea like, I know I can get in, but I'm going to stay here to help others try to get in. And really the story is that this is manifested in this tireless effort to help these beings of suffering kind of get across this bridge of difficulty and really achieving a lot. But then when turning their head, thinking that they're finished with everything, they see that there is just another sea of countless beings still in suffering, waiting to be ferried across by him. So overwhelmed, his head splits into 11 pieces. And the reformation of his head by Buddha is granted as 11 heads so that they can see in all these directions. And Avalokiteshvara reaches out to help someone, and because there's so much burden of trying to help with one arm, the arm shatters. And then Buddha reforms the arm into 1,000 arms to help all beings in needs. And so really this is a story of the Buddha is wisdom. The wisdom is you can't do it alone, you do it with community. And so this, I thought, was also a very nice story for the clinician. Listen, I get it. You're a stroke doctor, but you're working with an ED doc. You're working with a nurse practitioner. You're working with a nurse. You're part of a team. You're all together. You're not isolated. So you don't need to shatter under the strain, and your head doesn't need to split. So I thought those two things were really good, available things I thought, as vehicles for teaching. And then I thought that skill-based learning is part and parcel of adult learning, in the sense that it's, acquire a skill that has instant validity in the context of my professional expression. And this was a great example of a beautiful mental training methodology. And there are many different mental training methodologies. So this is a way to do mental training. Adult learners love learning skills that are verifiable and applicable. And simulation is really just about what I believe is the way education is going to more and more be delivered as the standard, which is it'll be a scaffolded learning where you learn things via textbook and talking and on didactics and maybe with an iPad and a 3D model. And then instead of leaping right into the hospital, you will go through a simulation. And that simulation, if it has the fidelity of a certain degree, can actually then be used as part of your feedback loop in your credentialing and maintenance of certification. And what's novel is, operationalizing a simulation curriculum for contemplative medicine practices. But what isn't novel is, all the pieces together. They've existed and people have written about it. And we use that to sort of validate some of our methodology.
So let me ask you, if I'm a patient having a stroke or a family member of someone who's having a stroke, will I be able to tell if my neurologist has gone through contemplative training? I mean, what traits might that doctor have that a doctor who hasn't gone through this training wouldn't have?
That's an excellent question, because, we're talking about outcomes here. And so a longitudinal study, one we wanted to do was essentially just have them look at this from a professional standpoint of burnout scores specific to residents pre and post and 3 months down the line. Now, what we really should be doing in addition to this is design a layer of doing some sort of randomized trial where the exposure of a patient to someone with and without the training can be analyzed. You can imagine that can be difficult to design because there are a lot of things that go into it, but that is an avenue. That's something that we can design. And I hadn't thought about that aspect of it in terms of a study design. The intention behind the training is to provide the patient with a more aware provider at the bedside, which is to say, this person is paying attention. I'm sure many people have probably had this experience where you meet people at a party and essentially you say hello, but there's not a lot of eye contact. You did exchange things, so you know some stuff about them. So like on paper, you met and you spent the same time, but there's someone else, same amount of time, but they made eye contact and you felt like you really knew them and they were aware of things. They paid attention to something on your lapel, which was a pin that you wore, and that sparked something, little bits of awareness in the environment that they manifested. So I think that's what the intention is to improve on always the doctor-patient or provider-patient relationship, which I think is always going to be driven by cultivating awareness in the moment.
Well, it's very interesting. Thank you so much for making time to tell us about this, Dr. Masoud.
Oh, my pleasure. Thanks for making the time.
My guest has been Dr. Hesham Masoud, the director of Upstate's Simulation Center. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.